what can throw this trend off? There are patients on certain medications, for example, that might affect this patient differently. Metoprolol might be one. Any anti-fever medications, anti-seizure medications would be another one. Beta blockers. I mean, all of these things are going to give me different readings for this patient. How does that negatively affect my patient?
I mean, I've talked about it before and have conversations often that I would argue in your drug box, ALS drug box you have now, beta blocker is probably the most dangerous drug. And it's going to negatively affect the patient's ability to mount a response to whatever their stimulus is. And lots of medications can do that. I mean, even as simple as, we're talking about Benadryl. Benadryl can dry you out. It can make it really hard for you to have the appropriate response. So there are medications, both over-the-counter and prescription medications, that really can affect the body's ability to respond to these situations. And that doesn't mean, I mean, there's other medications out there that even stop you from sweating, right? If someone's profuse sweater, it really bothers them, we can give them a medication. That's a terrible medication for someone to be on if they're going to be out in the heat, right? You've taken away the main way that a body cools itself down.
So other than submersion tanks, how are we treating these patients in the field? I mean, we talked a little bit about anticonvulsants if they are seizing, but is there anything else that we should be doing as medics or advanced providers?
Honestly, your mainstay is just cooling them down. I mean, we talked that obviously having when they're in a dunk tank, and we should talk about what that actually means, but we're going to put them into a solution of ice and water. Ice is going to be floating at the top because it's less dense, and we need to continually circulate that water around them, because just like we've all been in either a pool or whatever, and it's a cold pool, if you stop moving, you feel a little bit warmer because you're not getting that convection effect. You're not moving the cold water closer to your skin to then cool you off.
So how do you recommend doing that? Paddles?
If you've got a paddle, that's great, but I mean, I would stick, someone's job is going to be just to circulate that water. Just put your arm in there and keep circulating that water. If the patient's shivering, that's a good sign. I mean, that's what we want. We're going to monitor them in the tub. If you don't have a tub, you can do that. We talked about using the burrito method. So if you got a tarp, lay a tarp out. If you got body bags work. Basically, you need something that's waterproof, water resistant, that you can hold a cold ice water bath against the skin. And we're going to probably do that for about 20 minutes. This is not going to be it's fast, right? It's fast in the time frame if I can turn them around in 20 minutes. But it's not like I put you in the ice bath and instantaneously you're fixed. We're going to be here for a little bit. We need to cool you down. It's going to take a few minutes, 10 to 20 minutes, to get you down to a reasonable temperature before we can get you out. We want your mental status to return back to normal. And during that time frame, we're going to be doing other things, right? We need to, especially for if you're having seizures, altered mental status, we want to check glucose, right? We want to make sure that this is not also a hypoglycemic event that's causing the symptoms that we assumed was from a heat emergency. So if you've got cold fluids, you can run cold fluids on them. We want to get the patient directly out of direct sunlight, so whether that's people even holding up towels to shade them from the sun. If you've got a pole, tents you can set up to put them underneath. Those are all great things you can do, and you want to get these patients naked. Get all their clothes off. You're going to put them directly into the ice bath. You want the cold slurry as close to their skin as possible, and we don't want anything in between that. So typically that's down to just underwear. Leave them in their underwear for their decency, and then fully submerged in an ice bath or burrito. You can have an arm up. Arms up are more beneficial, but again, this is still more surface area, right? You've got 9% of your surface area in each arm. That should also be inside the water to cool them down if you can. If these patients are really altered, we're going to be supporting them. We want to make sure that their head's up and out of the water. But ideally, arms in. If you need IV access, pull one of the arms out to get your access, but they need to be in the water first to cool them down. You can then pull an arm out, check blood sugar, get your IV access, start your cold fluids for fluid resuscitation, because they're likely going to be multiple liters down. And then that can give you access to give medications if you need to. It could be that they're vomiting, so giving them Zofran is going to be appropriate in the situation. If they're seizing, giving them benzodiazepines. Even if they're erratic, if you have benzodiazepines, can probably be beneficial to them just to keep them a little bit calmer because they're just too hot to just cool them down.
Yeah. And I think you bring up a good point about the 20 minutes. I mean, it's going to take roughly 20 minutes. This, again, as they slow down, let's treat the patient where they most need treated, and at this point it's going to be lowering core temperature. And that's not going to be a 5-minute transport time on scene. Like, we need to slow down and treat the patient. And hopefully, especially at like big events where we expect this, they're already set up and ready to go. And I might not have ice in it yet because that's kind of a waste of time, but is just a water bath beneficial to the patient?
It's better than nothing. I mean, water's still going to be pretty good at moving things away. Ice is super helpful to get that gradient, to really pull that heat away quickly from the body. I guess I'd rather have them in water than I would in just air, and to have ice packs with them. So, I mean, that's the other thing you could, and probably you will show up to them, oh, they're really hot, we packed them with ice packs, and now they're super altered, and that's why you guys got called, right? Because those ice packs, you just aren't getting the conduction with the skin to pull all the heat out that you can.
I think it's also important to mention, we're not saying put the tub out there, fill it with water, and just dunk them in the water, because then that water is going to be just as hot as everything else, right? Yeah. So understanding where that water comes from, but we're talking about logistically, how do we get to that point, right? So some of the private agencies or whatnot maybe not have the resources, but if we're talking about fire departments, what does this look like? You know what I mean? Some places may do it on scene, right, if they have it made up. Sometimes we've done it at the fire station, so it just depends on the situation, on what we feel is best to get them to that point. I mean, what does every fire department have? It's got water, right? On every fire truck's got water. So, even at our place, logistically, depending on where we're at, we'll either call and have them set it up at the station, or we'll actually bring everything to the scene. It just depends on the situation and what kind of the side of town. And I don't know if that's similar over your way as well. Absolutely. I imagine it is, but
like I said, we're fortunate enough that our schools are starting to have these themselves, which is awesome. But who's to say there's not a car show at the YMCA, and I'm not going to take them to the pool there because that's an indoor pool and it's kept at 80-some degrees. Yeah, it would behoove us to bring the patient either to the firehouse at that point or set up there as quick as we can.
Yeah, which is a total change in mentality, right? We want to take the patient to the hospital, but I can think of the last two that we've done have been elderly patients, and we brought them to the station, which obviously delays transport, but identifying that this is what's most beneficial to that patient.
It delays definitive. Well, it delays transport to the emergency department.
Yeah.
It doesn't delay care. It expedites care, right?
Yeah.
So in your system, what you do is you've got a squad that goes out, identifies it. You can then have other hands saying, hey, I need the ice bath set up. So by the time you guys get there, you're ready to go in the bay, and you're ready to
Yep. We found logistically coming back to the station is better than going to the patient, right? If they've already got the ice tub set up on whatever campus or something like that, that's one thing. But if they don't have it set up, logistically, it's easier to bring it back to the station.
Yeah,
so.
Sure.
Yeah, absolutely.
Yeah. But I mean, I guess in an idealized world, right, you could have your supervisor truck start your shift off. Supervisor fills up a giant cooler of ice. That way you always have it there. And you've got the tub in the back of your chase vehicle that obviously takes up a big amount of space. You're going to have water for it. And getting that amount of water to fill a 100-gallon trough is not...
It's more than a PW can.
Yes.
But know your agency, know your events. I mean, obviously at the Geauga County Fair, if it's in the end of August and we expect hot weather, UH is always there with our cooling fans on the EMS side of things. There's a tub there ready to go. Same with us. If we have the car show going on, we're going to probably have that set up and ready to an extent. It's just know your events too. Yeah, we had a guy not too long ago that was cutting grass and collapsed in his yard cutting grass, but we're not going to be set up for that one per se, but we can deploy quick. So.
Yeah, and we do the same thing on our way at the fair. We have two tanks set up.
Yeah.
I mean, we switch out the water daily, and then we're just prepared to go get the ice, right? So we obviously can't leave it in there, but we've got tents and fans and all those sorts of things because those are when we're most likely going to see these patients at hot events or something like that.
And I think this is a good it's not necessarily a mandatory pre-arrival activation, but it's a good time to call the hospital too and say, hey, this is what we're dealing with. We're going to treat here. Be prepared for this. And that way, if you do need to set up whatever you might have, it gives you time.
Absolutely. And we can be there to guide you too, right? If you have questions for us. Very recently with your organization, they responded to, it was a hot day. It's summertime. Football players are out practicing, and they had a few heat emergencies. And I've got a phone call. Hey, we're here. We got a call for this. They're dunked right now. We're monitoring them. Everything's fine. We're just going to be here about 10 minutes before we transport. Great. Do you have any questions for me? I'm happy to help you out. And I think that all the athletic trainers have really gotten a great grasp on this. They've got a lot of knowledge when it comes to this, and kind of lean on them, especially at the collegiate level that we're talking about here, where they're going to drive it. You're just there more for support and to be able to start an IV and give fluids and give medications if necessary. Once that temperature comes down, then transport to us. We get labs, we check them out, and honestly, we discharged all those patients home after that incident, but it was, hey, we're going to prioritize the sickest patients in the 2 tubs we have. We're going to bring the other 2 patients that are okay but can just be managed with external cooling, don't need to be submerged at this point. Those are going to the hospital. The other 2 are staying here. We'll be there in 10, 15 minutes.
I think historically speaking, too, it's a confidence booster. Like anything else, we've been on calls where we sometimes refer to as the chief title as chaos has arrived on scene because things are just crazy. Then all of a sudden you'll get somebody there with a word of reason that'll just, the whole scenario will just calm down instantly, right?
Yeah.
Same with this. And you can say that, well, we've never dealt with this. It's going to be pretty crazy when it first happens. Well, I just told you, statistically speaking, it's up 117%, and not that short of amount of time. So by calling, even if you can just call the ED and get the doc like, hey, you know what, you're doing a good job. This is exactly what you need to do. That might be your source of calm that you can get and just better treat that patient.
Well, then make this, if you haven't had this experience, if you haven't had to deal with this,
play with it.
Well, make it a training activity,
Yeah.
right? This should be a great training activity. Pick on, you're in a battalion chief. I think that's your rank at your place. You're a captain, right? Let's dunk the battalion chief today.
Let's not. Let's dunk the new. No, I'm kidding.
But let's go through that practice session. What are we actually going to do? Like, let's get them in. Let's get them down. Wear a bathing suit. They get them down to bathing suit. Let's put him in the water. He can act limp. He can act aggressive.
Yeah.
He can pretend to have a seizure. You guys can hold him into the tub. Make sure you're circulating it. You're going to make him shiver. And then that's first time's out of the way. Second time is a lot easier after the first time.
Yeah, no, absolutely.
So I think and now the plan is this is going to be coming out July of 2026, kind of by purpose. Now is the time to practice that. We're getting into, it's going to be a hot summer. You may have already had a heat emergency, but if you haven't yet, this might be the reason and call to, hey, let's organize a heat training exercise. Let's do this. How are we going to do this?
Yeah.
Let's practice. Are we going to do this here at the station? Oh, we've got a softball tournament or whatever tournament that's happening over the summer at the ball fields. How are we going to prepare for this? Are we just going to go out there and preset in the morning our tubs? We're going to make sure there's water there. Are we going to have a brush truck there that can fill them up? Where are we going to get our ice from? Work through all those logistics.
I am a huge fan of not reinventing the wheel. And you've got a guy sitting here that their department's already actively doing this. My department actively does this. There's obviously protocols written for this already. If anybody's out there listening and doesn't know where to start, it's
ask your neighbor.
Ask your neighbors.
Yeah.
That's there should be no secrets in that form at the firehouse anywhere or EMS organization that says it's ours. Don't worry about it.
Yeah.
No, it's not. It doesn't work that way.
Ask your EMS coordinator if you've got one. If you're university hospitals or you're another hospital system, they're gonna have a protocol in there, or get you into contact with someone that can speak about this, right?
Yeah.
Whether you're a city fire department or you're a more rural department, those are going to operate differently. We can give you examples of how it's worked for them in the past, or how it's worked, or how it's not worked for them.
Yeah. The other logistic conversation that we've had is, if we're setting it up at the station, we've got commercial ice tubs, we've got the ice and the water. But if we're taking it somewhere, obviously we can get the water, but how do we easily obtain the ice? And the question then became, well, we can either somehow bring it from the station, which probably isn't logistically possible, right? How do we're going to load a tub with ice, then pick it up in a truck, pick it out of the truck? It just doesn't make sense.
Maybe you stop at Circle K and grab
that's
their
what
ice.
I was getting at. Yeah. So that's what we've got multiple sheets in town. So the conversation was, well, we'll just go in there. We're going to commandeer some ice and we'll deal with it after the fact, right? I mean, an ice bag's a couple bucks, but we'll deal with that after the fact because this is what that patient needs. So just different little logistical things that we've worked out either direction, whether we're going one way or the other.
You can't hardly throw a rock anymore without hitting a Dollar General, regardless of where you're at, and you know they have ice machines.
Right.
Yeah.
So I mean, even in our more rural departments in this county, there's a Dollar General around the corner in every one of them.
Yeah.
So get that established. You know, hey, we might need ice, and if we do, don't worry, we're going to pay for it, but we're going to grab it pretty quick, right?
I think it's also important to mention, how we're putting these patients in the ice or in the water. For the patients that are awake and maybe able to get themselves in there but altered themselves, they can just get into the tub. But if they're altered, unresponsive, they're seizing, those sorts of things, we may have to get creative, whether it's a sheet, whether it's a mega mover or something like that we can then manually move them, because we're not going to be able to pick them up by their arms and their legs and just set them down in the tub. So that's just something else to think about logistically, making sure you have those materials there with you.
And if we have daytime fires right now, even now in June, we're going to have the probability and possibility of firemen being exposed to extreme temperatures.
Yeah, so it's not just these patients.
It's not, and we don't even have to stop here. What about SWAT guys? What about the bomb techs? What about, it's everywhere. It's a global problem. So we need to be ready for all these circumstances.
Imagine construction workers, right? I mean, you're not talking athletes. They're just at their job.
Yeah.
It's hot out. They forgot to pack their Gatorade or whatever, and they go down, right?
Yeah. Yeah. Any of these guys, I mean, landscapers. It's not. It's a bigger problem than what we give it credit for, and I think that we should be better off to handle it.
What's our end game? So once we get in submerged, what do we?
Yeah, what are we targeting?
What are
we making them an ice
what's our
dunk them and that's it, right? Yeah.
Well, because again, we're still talking if I don't have.
Exactly.
Correct.
Yeah.
There's going to be two real answers, kind of.
So they're probably going to be emerged for 10 to 20 minutes. Okay. That's going to be the goal. We want their mental status to improve, right?
Right.
So, and you can give up to 20 minutes for that to happen, and you can call Med Control to help guide you in that. Ideally, if you do have core temperature, we want the core temperature to go under 102. 102 is about the time where we know the body can self-regulate at that point. But you want their mental. Basically, you're gonna go on your gut, right?
Right.
Man, this person was seizing before. They're not seizing. I'm having a conversation with them. Even if they're shivering, I don't care. I want to get them almost back to baseline, right? And then just kind of talk to them. If you feel like they're better and they can come out of the pool, they don't the tub, they can feel hot, they can have a normal conversation with you, they can walk to the ambulance. That's all great news. You're gonna put them in the ambulance. You're gonna turn the air conditioning on there.
So now our other normal
your
tasks are going to work better.
Yep, you're probably going to give them more fluids, right? Because the first 20 minutes you pounded in with a liter of normal saline. You're going to need probably another liter of normal saline. And then you're going to transport them to the hospital, and then we're going to take over. We're going to do lab studies. We're going to watch them. They're going to be in an air-conditioned environment. We're going to make sure we'll check their temperature at the hospital as well. And 9 times out of 10, they come in normal, right? Because homeostasis has taken back over and been able to regulate their temperature. We're going to check CK level, make sure that there's not a huge amount of muscle breakdown. And that's the big concern for these patients is rhabdomyolysis.
Maybe you have more than I have. Has there been any talk at the hospital level, working with the local departments? Hey, we don't have the tub, but this patient, say they came in from somewhere else, or they came in through the front door. Hey, can you bring your tub, or can we figure something out? You know what I mean? That's an interesting concept.
That is a good concept.
It's a different concept, right? Hey, I'm going to call my local department, and they're going to come do this and take the patient.
We've had those discussions on decon. For hazmat and other things, so that's not a big. That's not a big step.
It's just changing your thought process.
Well, I mean, from a decon standpoint, the hospitals typically are going to rely on local fire departments unless they're
we've already had those discussions.
Big organizations that have that built in, like tertiary care centers, but community hospitals aren't going to have that. But that's a great point to bring resources to us. And interestingly enough, that's the bigger conversation we're having, and from an emergency medicine hospital standpoint, ED standpoint, of where it talks about when a disaster happens, whatever that disaster is. Let's say you've got 10 people with heat stroke out there. That's a disaster.
Correct.
We are now overwhelmed. how do we bring resources to the hospital? Because essentially EMS has gotten really good at managing disasters. You've gotten really good at transporting patients, getting resources there. Now you're moving the disaster from the scene.
The hospital still has the disaster.
Now the hospital has a disaster.
You just moved it over.
Yeah.
Yep. And so now we're going to rely on our partners, EMS.
Yeah. So I think it's important to have those conversations, right? We got to build that ahead of time. It can't just be,
right.
hey, Chief, can you send me over because nobody's going to do that, right? So we need to work on that ahead of time. So
hopefully that's
the case.
and I think that discussion is being had in a lot more ways than people believe that it is. But it's just not one of those well-known, and at the same time, who needs to know that when that happens? Like, I mean, the ED physician should certainly know, like, we have a resource for this.
Yeah.
But, it's
making sure that everybody's aware of the resources. Yeah, I agree.
And, geez, any department transporting through my township should know that the resource exists here, too. If they don't have it, that there should be a, we got this, you got this.
Hey, we're going to divert you to the fire station.
It's crazy, though, right?
Yeah, it's a weird thought.
Well, I mean, but take it. Let's say that your township A, you've got a heat emergency, and your whole crew your duty crew is 2 people, right? You're out on that call. You call township B, hey, get your dung tub ready. I got a heat patient I'm bringing into you. You guys can prep it as they're rolling in hot to you.
Yeah, exactly.
Before the 20-minute transport to the emergency department, right? So, I mean, that's a totally legitimate way to help manage these patients.
So going back to our protocol a little bit, it talks about altered mental status versus not. And this is kind of the decision maker there. But it also talks about 20 mLs per kilo saline.
Yep.
I think it's worth noting that the saline isn't fixing your heat exposure.
Correct.
So I'd hate to see somebody get tunnel vision, because a lot of times we do, especially when we go back to what is normal for us. And most paramedics can start an IV in their sleep. Don't get tunnel vision by that IV. They need the water. Like, do that first, and then, like you said, if you can get an arm up, then work on it secondarily.
Yeah, I mean, if you look at protocol is, no matter what it is, you're going to try to cool them by whatever method. And then your second step is IV access and fluids, right?
Second step, yeah.
Yep, that's your second step. Your first step is cool them down, and if they're in that extremis, they need dunked, dunk them. And then your second step is IV access and fluids.
Yeah.
And that's an advanced skill. I mean, up to this point, we're, again, talking about basic skills. Anyone can put a patient into a tub to cool them down. Like, EMTs can do this. Bystanders can do this. We have athletics trainers do this, but that's really kind of the key step here. And then 20, we're talking about boluses. We give lots of fluids to patients anyways. 20 mLs per kg is a standard bolus for a pediatric patient. We kind of adopted it here for this, and that's your floor. That's where we're going to start at. If they're still
that's a good point.
Tachycardic, and honestly, they're going to probably be 3, 4, 5 liters of fluid down. If they stopped sweating, they're going to get multiple liters of fluids. We're talking about septic patients. If they're septic and hypotensive, they're going to get a 30 per kilo bolus of fluids for them. But even for pediatric patients, if they're a sick pediatric patient, giving multiple 20 ml per kg boluses is totally acceptable. In fact, getting 2 is not even unheard of. At that point, we then consider they're appropriately fluid resuscitated. For adults, it can be a lot of fluids. Yeah. I mean, if you're giving, we'll just take a 100 kilo individual, because it's just easy math, right? 100 kilo patient, 220 pounds, they get 2 liters of fluid right off the rip. If you were just talking 20 per kilo of fluids, that's 1 large bore IV and bilateral ACs, right? Run over as quick as you can. That's 20 minutes right there. That's 2 liters of fluid. That's your first bolus. It would not be unreasonable if they're still tachycardic to give them a second liter of fluid, 2 liters, right? So you're at 4 liters of fluid resuscitation at that point. Yeah. I would then consider them more appropriately fluid resuscitated at that point. Obviously, in the emergency department, I've got other ways of assessing that, but you guys can just by their heart rate to make sure heart rate, blood pressure, those types of vital signs, to make sure they're appropriately resuscitated from a fluid standpoint.
And these people would be vasodilated, wouldn't they? I mean, because isn't that how I get my hot blood?
Yep.
To my skin.
Yep. It's prioritizing trying to cool you down. There's
nothing there to do.
Yeah.